The first section for today is going to be on valvular heart disease. Okay? Valvular heart disease basically leads to several problems over time. Eventually you get cardiac failure, which we consider congestive heart failure. You may actually also develop severe forms of cardiac muscular dysfunction and also develop sudden death in some patients. Okay? The pressure overload conditions such as aortic stenosis, mitral stenosis, pulmonic stenosis, if you do develop that, although it's fairly rare, okay, will lead to eventually hypertrophy of the muscle that has to pump against that very stiff valve. This leads eventually to hypertrophy development. Most of the time when you're looking at pressure overload conditions, you're looking at the aortic stenosis, and so you get this very significant widening of the actual cardiac muscle. This is the actual left ventricle. You can see how it's actually concentric in shape in comparison to the right ventricle, which is actually pyramidal in shape. Unfortunately, if you let this sit for too long, it eventually causes cardiac dilation, and once that event occurs, you can't get reversal. Okay, so if you are going to go in there and repair that problem, all you're doing is you're stopping the progression of the disease, and you may improve the symptoms a little bit, but overall the patient's not going to revert back to a normal heart. Examples are considered aortic stenosis, pulmonic stenosis. Mitral stenosis would cause hypertrophy not of so much the cardiac ventricle, but of the actual atrium. Tricuspid stenosis would also do the same thing. The atrium is also a very thin cardiac muscle most of the time, so you don't get the degree of hypertrophy that you would see in this thing and you see in the left ventricle. Volume overload conditions lead to very early dilation, okay? And that's a problem because, again, you're disrupting the architecture of the heart, and as a consequence, you don't get returned back to normal function if you do repair the valve. Eventually, you do get cardiac failure because the ventricle begins to overload and get so big that it has excessive preload. Examples of this are typically mitral regurgitation and significantly aortic regurgitation, which accelerates and goes much more rapidly than MR. MR can be persistent for about 20 to 30 years. AI, on the other hand, will last maybe 5 to 10 years, depending on how bad the person's hypertension may be at the time. The preoperative evaluation of these people is that you got to know what you're dealing with. You have to know the severity of the disease, how bad is the valve function that you're taking place. Okay? You also have to know the degree of impaired cardiac contractility. If you have a significantly impaired cardiac contractility and you put some of these people to sleep, you may also have big problems. Sometimes you're not actually doing a valve repair, but you're doing a general anesthetic for somebody, or you're doing an anesthetic for some kind of surgical procedure. And some forms of anesthesia are contraindicated in certain forms of valvular diseases, and you should know those. Okay? A lot of times you get stuck having to do obstetrical patient for delivery, either C-section wise or labor, and the woman has some form of valvular dysfunction when you listen to it carefully, and sometimes you can't differentiate it because there is a certain degree of murmurs that occur during pregnancy as well. So you could have a mitral regurgitation that occurs normally, okay, because the heart does dilate during pregnancy. But if you have something else like aortic stenosis, that might be a completely different animal to deal with. Okay? Putting them under an epidural is kind of contraindicated, and you may actually kill the patient in the process. So you have to know which valve dysfunction you're dealing with. Okay? Eventually, because of cardiac failure, you do cause, especially the left ventricle, causes failure to systemic organs. So you tend to also get a back pressure development as well as in the respiratory side of it. So the respiratory side, you get congestive heart failure, pulmonary edema. The kidneys, the brain, and GI tract, which high oxygen extraction rates, are the ones that fail first. On the right side ventricle, the lung stays clean, in a sense dry in that point, but the liver and also the spleen becomes enlarged in that kind of situation. The liver failure will end up causing problems with coagulation possibly, and you may also develop portal hypertension with variceal hemorrhaging and death from that. Preoperative evaluation, of course, is always obtain a good history and physical. Ask about the person's exercise tolerance, how far can they walk. The less exercise tolerance that the person has, the more severe the valvular disease tends to be. The other thing that also is pick up, you can sort of tell what's going on, is that the person will develop significant amounts of arrhythmias and palpitations. Okay? If you do have somebody that's being evaluated, they should have a New York Heart Association classification of the degree of failure that they have. Document all the symptoms that you're seeing. That way somebody else can follow through with it and find out if the symptoms are getting worse or better. And then auscultate for heart sounds, and that's very important. I expect anytime that you plan to do a regional anesthetic on somebody, a spinal or an epidural, that you'll have your stethoscope on you and you'll be listening on all your patients. And that's something, a habit you need to get into, because invariably about 1% of all valvular dysfunctions are not picked up before surgery. I'd say more, it's like 10%. The books say 1%, but I don't believe that. There's, especially now with all the extenders, everybody listens to the heart and says everything's fine. And there's nobody that's a professional at listening to heart sounds anymore. As nurses, how much time was spent on listening for valvular dysfunction? An hour, 3 hours, 20 hours? How many hours have we spent on teaching you? Okay, so I guess I need to spend some time with teaching you guys as well. I'm going to make sure that the other classes that involved with physical diagnosis, I'm going to try to get in one of those classes that gets you to teach you a little bit more about heart sounds. Cardiac dysrhythmias are very commonly seen as well, and sometimes that's usually the first symptoms that a lot of these people would develop. This is actually showing you the extent of the actual involvement, okay, from different valvular dysfunctions that can occur. You can read this on your own a little later on, but this is sort of a little example. It shows you that the atrial natriuretic factor may be activated. You may actually get over diuresing as a consequence, or you may actually have retention of fluid depending on the situation. The New York Heart Classification basically looks at the degree of failure that the person has. A person who has class 1 is considered asymptomatic. Class 2 is the symptoms with ordinary activity but comfortable at rest. It becomes important at class 3 and class 4. Class 3 is when they become symptomatic at minimal activity. And class 4 is the most dangerous to put to sleep because their symptoms are at rest. Auscultation, what I expect you to pick up on murmurs. You have to know the systolic murmurs versus diastolic murmurs. Okay? Systolic murmurs occur, of course, when the left ventricle and the right ventricle begin their contraction phase. Okay? Systolic murmurs such as aortic stenosis can be picked up during that time period. Pulmonic stenosis can also be picked up. Mitral regurg as well, because that's when the valve opens during systole, and tricuspid regurgitation as well. All the diastolic murmurs are bad as well. Okay? The systolic murmurs could also be full murmurs that can occur sometimes from a very mitral valve prolapse or a small degree of aortic sclerosis, not stenosis. And that can be normal. But diastolic murmurs are always invariably tends to be pathological. Okay? So when you hear somebody in between, and the way you pick it up too is you take the person's pulse. Okay? During systole you hear for murmurs, you'll feel the pulsation, and that's a systolic murmur. When you don't feel pulsation, you hear a murmur, that's a diastolic murmur. Okay, diastolic murmurs account for like AI, aortic insufficiency, pulmonic insufficiency, mitral stenosis, and tricuspid stenosis. Okay? Now, preoperative evaluation, you need to know the drug therapy the patient's on, of course, laboratory data, including echocardiogram being the most important of all these studies, because it demonstrates to you pretty much what kind of valvular abnormality you have. And then you also want to have a cardiac cath study because you want to know if you have an underlying coronary artery disease that you might have to deal with. This is what happens to somebody who develops congestive heart failure. Okay, you can see the extensive amount of pulmonary edema that this patient has developed. And these are the kind of things you have to look for. You see the out here, the curly B signs, which can't really be seen all that well, but this is extensive pulmonary edema. Cardiac cath provides you with the presence of severity of valvular disease. It tells you about the coronaries. It also tells you about if there's any intracardiac shunts taking place. And the transvalvular gradients can also tell you significant amounts of how severe disease process is taking place. Anything greater than 10 millimeters of gradient for mitral stenosis is considered severe. And the higher the velocity that it tends to go through a valve, it means that it usually generates a greater gradient. Okay? So aortic stenosis gradients can be generated as much as 50 millimeters of mercury. Now, what is a gradient? Okay, what the gradient is a difference between the expected pressure on one side and the actual pressure that's generated by the chamber that's pushing the volume. And I'll show you that in a second what I mean. Okay? Measurements of pulmonary pressures are also important by cardiac cath. Echo density determines the significance of the cardiac murmur, identifies the hemodynamic abnormality. Especially the transesophageal echo is what we tend to do now when we really want to have very clear viewing. Okay? The reason transesophageal echo is so great is because you're actually looking at the heart from the posterior aspect through the esophagus and looking without having the interference of the lung. When you do transthoracic echo, usually the lung is always in the way of the viewer. Okay? And that gives you a certain degree of artifacts. Okay? But TEE is by far the gold standard, really pretty much now. And we do a lot of sedation for TEEs. Determine the valve area, determine the ventricular ejection fraction. So when you're up in endoland, when you're doing your rotation up there, don't be bored. Listen to a lot of the murmurs. There's a lot of cool murmurs that you'll hear. And then you can pick up and something that, that you may not be able to will actually make a big difference later on in your career. Determine the valve area. It determines the ventricular ejection fraction as well. A diagnosis valvular regurgitation and the degree of it. And it can actually evaluate prosthetic valve function as well. If you have a prosthetic valve present, you have to know the different kinds that there are out there. Okay, pretty much we're going to more bioprosthetic devices. But in the old days, we used to have mechanical devices. We used to have what's called a ping pong valve in the past, because it actually looked like a little ping pong ball inside of a cage. You could tell across the room that you had a ping pong in the patient because you could hear the click, click, click every time the heart beat. It was pretty impressive. Most of the valves now are pretty so quiet you don't hear them anymore. You have to hear them pretty carefully with the stethoscope. When it's mechanical, you can still hear it, but not so much like it used to be. And that because the flow velocities are so different. St. Jude valve is considered a mechanical valve. It's got a double wafer that's in it. It has some degree of echogenic regurgitation that you see invariably. The problem with the mechanical valves is that they are mechanical, and because they're mechanical, they tend to cause thrombosis. And they're thrombogenic, so there's increased incidence of developing clot in these patients and embolization. So they basically require long-term anticoagulation. The great thing about them is you can put them in a 20-year-old and they'll last till they're 50. That's a pretty good deal. Okay? The bioprosthetics, on the other hand, they come from many different sources. Most of the time they used to come from pigs, but now they're coming from bovine, which means that they're coming from cows. They also sometimes come from homografts from mature humans. The actual failure rate is around 10 or 15 years. That's the big problem with them. So if you're putting it in somebody who's 50, you'll get it to last, till they're 65 possibly. But if you do it in a 20-year-old, you're reoperating again in their 30s, and they're 35, 40 years of age. The nice thing about them is they don't require anticoagulation after this. They've actually established themselves. So that's kind of a nice thing. This is the ping pong, which is called the Starr-Edwards ball and cage valve. Okay? Thank goodness we don't have this sucker anymore. Okay? Because you live in Naples, I heard one of these the other day, and it brought back all these memories. So it was like, wow. And I went up to his wife and I shook her hand. And I said, why are you shaking my hand? She says, well, you're one of the few women I know that actually will stay with a man for 20 years after they've got a valve replacement like that. A lot of people got divorced. The people who were living with them would go crazy from the sound. They click, 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 click. Okay. So it gets to be irritating. Complications of the prosthetic valves is there's valve thrombosis. Coumadin, heparin are the treatment of choice, Coumadin being, of course, a long-term therapy. Systemic embolization, which means brain infarcts, including GI, are very, very severe complications. Sometimes, anytime anybody comes in with severe abdominal pain that has a biomechanical valve in place, consider that you just throw embolus to the GI tract and the person may have an ischemic bowel. So even if they're fully anticoagulated, invariably it's what it is. Okay? You may also get structural failure, which is I've seen that happen. That's pretty impressive. The valve will lock in place. Okay? Partially, if it's a bivalve, that's why they do put bivalves in. Sometimes one of the valves will lock, and the person will be very, very bad shape. If you have a univalve and the thing locks, it's over. So you find out in the pathological examination of that patient. You may also get hemolysis, which is long-term, so you get iron deposition in the body. Okay? And then you may also have some degree of paravalvular leak. They used to tell us that they did this on purpose, engineers. I used to laugh. I said, yeah, right. The new valves are so much better that you don't see any paravalvular leak anymore. They're really clean. Okay? The in between the middle of the valves, usually it leaks a little bit, but now with the valves being so well designed, you almost get zero regurgitation at all. Around the actual annular suturing, sometimes one of the sutures will break loose, and then you'll get paravalvular leaking through that as well, which is abnormal. Anytime you see that kind of leak, it's considered abnormal. The other thing is that these people have a considerable increased risk for developing endocarditis. Bacterial endocarditis is something you have to fight. You want to make sure that anybody who's got a valvular replacement, you've got to make sure that they don't get infections. So there's been a radical change in this. We used to give a lot more antibiotics before, but we only take and give it to the high-risk patients. Patients that have prosthetic valves, okay, previous infective endocarditis, congenital heart disease, or cardiac transplant patients would develop cardiac valvulopathy. Dental procedures are considered high risk. Invasive procedures on the respiratory tract. Anytime you enter the mouth, you're causing risk of infection in the teeth. Skin structures, musculoskeletal tissues. The thing that's really kind of most of people surprised by is that you don't give antibiotics to patients who are getting colonoscopies or upper endoscopies. Okay? You also do not do it for cystoscopies. Okay? That's if you don't think that there's UTI. If there's an underlying UTI, you do treat it. Okay? So it's only for people that are normal in that respect. We give for gram-positive, gram-negative coverage. Typical example, that's amoxicillin. And that person is allergic to penicillins. There's a 5% crossover rate with the cephalosporins. But if you think that the patient's tolerated before, you can give them cephalexin or cefazolin IV. Or you can use the secondary agents such as avoiding the cephalosporins completely, which is clindamycin or azithromycin or clarithromycin. And those are the ones that we tend to use when you have patients that are allergic. Now let's go through individual disease-brought valvular dysfunctions. The first one that we're going to talk about is mitral stenosis, which is the most common cause. It's due to rheumatic fever. The rare causes which do occur, but thank goodness they're rare, are due to cancers at times, which are called carcinoid syndrome, and sometimes development of a left atrial myxoma. You can also see it in inflammatory autoimmune diseases such as rheumatoid arthritis, lupus, and sometimes you may also see it from congenital problems, which is called congenital mitral stenosis. This disease, because it's due to rheumatic fever, is mostly affected by women. Okay? It takes about 20-30 years for mitral stenosis to develop, so it's a long-term disease process. And it needs to be picked up earlier than later. Okay? If you wait too long, then the person will develop primary pulmonary hypertension, and they'll have big problems. Okay? So picking it up by listening and hearing basically a diastolic murmur, okay, will actually be able to treat this patient more aggressively. If you wait too long, the mitral stenosis will actually start causing dilation of the left atrium. That dilation is a compensatory mechanism which allows for not so much pressure to develop in the pulmonary arteries initially, in the pulmonary veins. Eventually, once the compensation is no longer able to do that, which means that usually the left atrium is very much enlarged, leads to elevations in pulmonic venous pressure, which eventually leads to congestive heart failure, pulmonary hypertension, and if it persists for too much longer, it develops into right-sided ventricular failure. The normal valve area for the mitral valve is around 4 to 6 centimeters squared. Symptoms occur when there's a 50% reduction in the valve area when you're less than 2 centimeters squared. Remember, anytime you see a 50 to 60% reduction, usually that's become significant. The mean arterial atrial pressure, once it's less than 1 centimeter squared, okay, is very severe. You usually have a very significant gradient, 25 millimeters or greater. It increases the risk of long-term pulmonary hypertension if you get to that point, even if you do replace the valve. Initially, you have an inability to fill the left ventricle during diastole, so mitral stenosis is a preload failure to the left ventricle. The left ventricle is dying from a lack of volume. Okay? You get an increase in left atrial volumes and pressures, and you eventually get left atrial dilation, subsequent increase in PA occlusion pressure, which is consistent with elevations in what you call pulmonary venous pressures. This eventually leads to an increase in pulmonary artery pressures, eventual pulmonary hypertension, and right ventricular failure. In mild MS, you get left ventricular volume tends to be okay, but the left ventricle systolic stroke volume is adequate at rest most of the time. The problem with this is under mild MS, there's an increased risk for development of significant arrhythmias such as atrial fibrillation. What happens when you develop atrial fibrillation is you lose the atrial kick, and when you have a very tight valve, that can be life-threatening or even lethal. So atrial fibrillation in this person can actually kill them. It limits the diastolic filling time, it decreases their left ventricular volume, and it causes a decreased stroke volume, which then may cause symptoms. In moderate to severe MS, you have increases in left atrial volumes and pressures. You see these big increases in PA occlusion pressures, and you start getting transudation into the pulmonary interstitial fluid space. So these people are developing early signs of pulmonary edema. They also start showing increasing lung weight with a decrease in lung compliance. Okay? And as a consequence, you get an increased workload breathing. The patient develops an increasing dyspnea, overt pulmonary edema eventually develops, and you may develop severe forms of hemoptysis at times. What you see in this kind of situation is that the preload state is severely depressed. Okay? So when you look at our friends here, the pressure over volume curves, okay, here's your normal preload curve. This is for the left ventricle curves. Let's do the first normal. Here's your normal curve. What this person is suffering is not that this is the mitral valve opening. Mitral valve opening is limited for short durations of period of time, and so the left ventricle is actually getting inadequate volumes. So it's a low preload state situation. Okay? So in these patients, you have to give them adequate preload, otherwise they get into trouble. Okay? So drying this person can actually kill them. Okay? This is one of the situations where you get an enlarged, what? Not V wave. A wave. Enlarged A wave. Okay? You get an enlarged A wave with this patient. Okay? Because every time the atrium kicks, it causes an enlarged A wave. Okay? So you will see that the person, instead of being, I'll do the normal first, you get a PA occlusion pressure that looks like this, A, C, V. That's your normal. Person with mitral stenosis will get a large V wave, A wave, sorry. Okay. Now, how that will be seen when you're doing your PA occlusion pressure is that you'll see this, of course, okay, but your PA pressure, let's do the normal first. Okay, normal pressure looks like this. It's your normal PA pressure. Okay, underlying this is, of course, your PA occlusion pressure. And with somebody with severe mitral stenosis, you get an enlargement of this portion. What the consequence will happen is that you'll get the following. Come on. Okay, so you get that kind of pattern. So it looks like somebody put their fingers up like that, a Boy Scout sign. Okay, you get the first pattern is from the atrial kick and the normal ventricular contraction, and then you have your rebound effect, which is your dicrotic notch. Okay. Mitral stenosis can be diagnosed, of course, by echo. Okay. One of the things that I want you to specifically understand is that you have to look at the left atrial appendage, and the reason you're looking at this area is you're looking for clot. Okay. We actually had a lady the other day that came in. She ended up dying in the ICU within 4 hours after we left. Okay. She had mitral stenosis, which was never treated, but it wasn't very severe. The problem with it was that she had a large clot sitting in her left atrial appendage when we looked during the case. It was rather impressive. The problem with it is, of course, that she threw a clot to her GI tract and caused a massive ischemia of her GI system. Yes? What's that? Tricuspid stenosis. Tricuspid stenosis would give you basically a dry heart and a dry lung. Okay? With tricuspid stenosis, there's no volume getting into the right ventricle or the left ventricle, and the pulmonary circulation actually remains fairly dry in the sense that there's not extra volume sitting in there. Okay? The waveform would actually look like a CVP with an enlarged A wave, normal, possible C, and a normal V. Okay, but you'd have a definitely enlarged A wave. The PA waveforms would look normal. It would just be low. The PA occlusion pressures would be normal as well. Okay, just the CVP would change. What's that? The PA waveform is because it doesn't reflect any changes inside, and there's no valvular abnormality that affects the pulmonary artery pressures at that point. The pressures would be low, and that's about it, okay, which indicate low volume. But it would actually not change the actual waveform itself. The CVP is the only thing that you're looking at when you're looking at the right atrium. Okay, so there's nothing else behind it besides the CVP. So it doesn't affect the pulmonary arteries at all. Okay? The pulmonary artery pressures are affected because the venous side of it is reflection of the left atrium. And that's why it can actually reflect what's going on in the left atrium. Okay. Right. It's about 1 centimeter width. Okay. And one of the problems that you have is when you have a stenotic valve, it can be very difficult to get it through. Can you get it through? The answer is, should you get it through? If it's that tight, and the answer is no. Okay, so if you're having a hard time trying to get the catheter through, and it's down to less than 1 centimeter, that's pretty tight. Okay, most of the time we tell you don't put in the PA catheter for that situation. Just leave it in the right superior vena cava and just wait till they finish repairing the valve. Okay. Yes. Okay, what she basically asked, what happens to the occlusion pressure when somebody develops mitral stenosis? Okay, the answer is that it rises inappropriately. Okay. Okay, for tricuspid stenosis, the PA occlusion pressure is actually normal or low, most likely low. Okay, and when you look at the waveform for the PA occlusion pressure, it looks absolutely normal. Okay, it's got a normal A, normal C, normal V. Okay? So if you do get the pulmonary artery catheter in and you put a wedge up, it'll be lower than normal, okay, because there's low volume states inside the left ventricle. Okay? But if you have mitral stenosis, on the other hand, okay, what you'll see is you see that the machine will actually tell you that the person has a high PA occlusion pressure. Okay? And in reality, it's not. Okay? Because the actual C wave, which is the actual indicator of how much volume you have in the left ventricle, is actually on the lower end. Okay? The danger of that is that some people don't recognize that they have an abnormal waveform for mitral stenosis, and they will begin to diurese the patient thinking that this person is in pressure and volume overload situations. They will end up drying out the left ventricle and cause the person to develop renal failure very quickly. I've seen that happen before. So you got to be very leery of that. This is what the echo shows you. Shows you the degree of gradients that you may have. Okay, when you have severe gradients of gas greater than 10 millimeters of mercury, if you see the mitral valve area is less than 1 centimeter squared. Mitral stenosis is diagnosed with a diastolic murmur. Okay, and the diastolic murmur gives you like a mitral snap. Okay, it's a rumbling murmur that occurs right after S2. Treatment is mild. You can give a little bit of diuretics in these patients, but be very, very, very careful. Okay? And this is for only mild. Severe, forget about that. You're not going to do that. Control heart rate. You want to prevent atrial fibrillation. Okay? So patients should be placed on beta blockers and calcium channel blockers, and they should be anticoagulated as well. For severe to moderate, okay, it really should be surgical correction. I've seen enough of these percutaneous balloon valvotomies to not be impressed. Anybody who tells you, oh, we're going to do a valvotomy, you should shake, it's going to be a bad day. Okay? Because it's usually somebody who's so sick that nobody wants to operate on them. Okay? And then you're asked to go help. Okay? And usually when they put the balloon up to break up the valve, to open it up, it crunches and it releases calcium, and the person can embolize, which I've seen that happen. The worst cases that I saw was the balloon went up and they couldn't put the balloon back down because it got jammed inside the valve. That was a lethal event. Okay? And it was very impressive pulmonary edema. It was within 3 heartbeats. The amount of foam that was coming out of the person's mouth was pretty impressive, and we intubated him very quickly, almost within 30 seconds, and it didn't make a difference. Yes? It's to prevent basically atrial flutter, atrial fib from going into SVT. You can decide which one you want to use. Okay? If the person's in failure, a lot of us will use DIG. Okay? Most of us are now going to calcium channel blockers because they're more predictable with less toxicity. So we tend to use the cardizem, things like that are AV node blockers more than peripheral vasodilators. Okay? The downside of beta blockers is they slow down the heart sometimes too much, and you get into failure from that as well. So you have to be a little bit leery of it. Okay? A lot of these people develop tachydysrhythmia, so giving that beta blocker sort of helps prevent that a little bit. Okay, but you can't go crazy. What you need to do is you need to start taking that person in the operating room, get them there sooner than later. Okay? I've seen people wait too long, and that's when you get into trouble. Management is avoid, when you're doing your induction, you don't want to let that person get tachy on you. Tachy is not going to be good. Okay? Anybody that tries to increase their heart rate with a fixed valve like that and has a weak muscle to try to push the volume through it is very dependent on rate. Okay? The longer the time you have between the 2 heartbeats, the better you're going to have to be able to fill the left ventricle. Okay? So mitral stenosis should be avoided, sinus tachycardia or rapid ventricular response. Okay? You marked increase in central blood volume as associated with overtransfusion or head down position. So be careful with that as well. These people are grossly over volume, so adding more volume to them doesn't seem to help. You also see drug-induced decrease in systemic vascular resistance will make the situation not better. It'll help empty the left ventricle too much, and then you'll get more situations. Okay? Hypoxemia and hypercarbia may actually exacerbate pulmonary hypertension, okay, and evoke a right ventricular heart failure. So that's one thing you don't want to do. Remember, there's 2 rules about HPV. HPV is hypoxia, and the other one that actually causes pulmonary vasoconstriction is hypercarbia. Okay? Hypercarbia will cause pulmonary vasoconstriction. It acts like HPV in a way, and it's trying to shunt blood to areas that have less CO2 in it because it thinks it's better ventilated. Okay? Yes, sir. Nitrous has mild pulmonary hypertension issues. I've seen it used enough in hearts that I don't think about it too much as being concerning to me. If somebody really has severe MS, okay, then I would try to err on the side of being cautious. So I would just go on the low side. If it's giving me trouble, I'd shut it off. Okay? Most of the time we're doing cardiac cases at this point to repair this, so we're not using a lot of nitrous at that point. We're using mostly nitrous narcotic technique with benzodiazepines, and we're now using volatile anesthetics a little bit too. Okay, I already went through that. Okay, preoperative medications used to decrease anxiety, reduce tachycardia, maintain your beta blockers, and diuretic-induced hypokalemia should be treated prior to induction, as it increases the risk of atrial fibrillation. Remember that atrial fibrillation and all forms of tachydysrhythmias are made worse by hypokalemia, so you want to make sure that that's corrected. And then you watch for anticoagulation. Induction, the only drug that I think is contraindicated in mitral stenosis is pretty much ketamine. Don't use ketamine because it causes tachydysrhythmias. Okay. Also avoid histamine-releasing drugs such as atracurium, not some appropriate. Avoid elevations of heart rate. and consider ESMO to prevent tracheal stimulation. Maintenance, heart rate, sinus rhythm, SVR, and contractility all have to be pretty much the same. The regimen, sometimes you can actually use a nitrous narcotic technique as long as you want to, as long as pulmonary hypertension is not present. Is there just what your question you were asking? Balanced anesthesia with low volatile, which is what we tend to do. Muscle relaxants that are cardiac stable, such as becloronium, they are used. If you're using high doses of fentanyl, then you can use Pavilon safely, okay, because Pavilon, when combined with fentanyl, doesn't really increase your heart rate at all. Be careful with your reversal. If the person has a valvular disease after this operation because you're not redoing a valvular replacement, then you've got to be really leery of giving that person glycopyrrolate. If you give the 1-to-1 combination of glycopyrrolate and neostigmine for reversal, you get a 30% increase in heart rate, which is pretty significant. Okay? If you drop it down by 1 cc, you get a 15 to 10% increase in heart rate. So that's a little bit more acceptable. And that's what I tend to do in most of my cases anyways. The thing is, the trick to it is you must give at least 0.4 of Robenal. Never go below that. Okay? Light anesthesia is dangerous because what happens in these patients is you can get tachydysrhythmias very quickly from sympathetic stimulation. So you've got to carry them with enough anesthesia on board. If you're worried because you think you're giving them too much anesthesia, then put a BIS monitor so you can monitor a little bit closely what's going on. Okay? But keeping somebody light, it doesn't do them any favors. Okay? And sometimes you hear people tell you, well, you know, I want this procedure to be done under just sedation, okay, because it's less stressful on the heart. Yeah, right. Okay? I can tell you a good anesthetic is very safe. Okay? The worst possible situation to be in, and I know somebody in our operating room who was so fearful of anesthesia when she was younger that she refused to have a general anesthetic for an appendectomy. Okay, and they did it under a local. Okay? It was brutal. But she told me it was the worst experience she's ever had in her life. Okay? Well, yeah. I mean, somebody cutting on you while you're awake and you can't move because the local anesthetic doesn't work well enough. That's why you have general anesthesia. Now, the reason she tolerated it was she was young. Okay? You do that to a 70-year-old, the person will have an infarct right in front of you. Okay? Pain can kill you. Okay? The idea that, you know, that no pain is good, I tend to agree with. Okay? It's better to have at least a little bit of, least amount of pain as possible because the sympathetic overstimulation you can get can actually do you very great harm. And that's what people sometimes forget. But you can also see surgeons that don't like anesthesia for some reason. They have their old biases. And then they say they can do enough local, and the joke at the end of the case is you're holding the patient down, and you're chemically trying to keep them down while the surgeon's not doing a good job of localizing the patient. If you have that kind of surgeon, just put the patient to sleep. It's just so much easier on you and on the patient. The other thing is you got to watch for fluid overload. This leads to pulmonary edema, so giving this person a lot of fluids may not really work because it's not going to get across the valve. Treat as normal if you have mild mitral stenosis. If it's a complex procedure, treat as severe MS. So in other words, if you have something intra-abdominal or intrathoracic you're going into and you have mild MS, treat them like there's a true MS, which is give them an A-line, PE catheter, do the works. Okay, put the TE on them as well. Might as well. Keep yourself safe. Okay? In moderate to severe MS, you have to do the full gamut of cardiac anesthesia, which is to do the three things, A-line, PA catheter, and TEE. The problem with the PA catheter, sometimes people feel it's contraindicated. I think so too if the person's not well trained with it. In that case, throw a TEE in, you're much safer. The reason being is because the pulmonary artery catheter is in a system that has some degree of pulmonary hypertension. And if you inflate the PA catheter too rapidly, you can rupture it at a higher rate and cause severe problems. Postoperative risk is, of course, development of pulmonary edema, right ventricular failure. If you get tachycardia, may induce hypoventilation. Tachycardia may be induced by hyperventilating somebody, which then drives the CO2 levels down. You can also get tachycardia may induce hypoventilation, which then causes elevations in CO2 and hypoxemia, which then makes the actual right ventricular failure get worse. Okay? So both sides is bad. Okay? Hyperventilating is bad because you can go into tachydysrhythmias because you're driving the potassium back into the cells. and hypoventilating is also bad. Okay? Unfortunately, everybody after surgery does what? Everybody hypoventilates. Everybody is hypoventilating. Everybody's CO2 level is elevated post-op, which increases the risk of developing increased, right ventricular failure. Sometimes you'll see mechanical ventilation is needed because the patient has decreased pulmonary compliance and increased work of breathing. Mitral regurgitation is the next one. Okay? Mitral regurgitation has many different roles. Okay? The most common one that I want you to think of is, of course, mitral myocardial ischemia, especially if you have new onset of mitral regurgitation. Okay? It's usually assigned that the myocardial is ischemic and is causing papillary dysfunction. You may also get you may also get annular dilation, which can occur from too excessive a preload. And then the worst possible situation is if you get rupture to the chorda papillary muscles. That can be a very devastating complication, and pretty much the pulmonary artery pressures reflect systemic pressures at that point. You may also have some degrees of mitral valve prolapse, congenital defects such as Cushing defects, left ventricular failure, leading to left ventricular hypertrophy, and cardiomyopathy may also lead to mitral regurgitation. Some degree of autoimmune diseases such as lupus, rheumatoid arthritis, and ankylosing spondylitis will also begin to affect the structure of the valve and basically cause it to regurgitate. And then, of course, if you have infectious endocarditis, it can cause this problem. Trauma, deceleration injuries will also rupture papillary muscles at times. The left ventricle is usually not the one at risk, but mostly the right ventricle is. So you're talking about mostly for trauma, tricuspid regurgitation, not so much mitral valve. Mitral regurgitation, you see a decrease in stroke volume because what you're doing is you're emptying the volume into the left atrium. This leads to left atrial volume overload that occurs very rapidly, and which leads to a rapid increase in pressure depending on the acuity. If you have somebody with mitral regurgitation that's gradual, then you have the left atrium will dilate. But under ischemic events, usually that doesn't occur because there's been not enough time for compensation, so the left atrial pressures rise rapidly in that situation. As the pressures rise in the left atrium, it starts reflecting back into the pulmonary venous pressure, which then causes pressures and causes extravasation of fluids from into the interstitial space initially, which is stage 1 pulmonary edema, and then eventually to stage 2, where actually the fluid goes into the alveoli. The myocardial ischemia due to MR is rare, rather the result. Okay? That's really an important statement. There's been sometimes in literature people have said that mitral regurg leads to myocardial ischemia. It's the other way around. They got it wrong. Okay? The process is completely the opposite. Mitral ischemia results in MR. Okay? And then I can tell you that I've seen it so many times now that it's sort of like it's pathognomonic that ischemia is taking place inside the left ventricle. We actually had this happen the other night, and once we understood what was going on, we got ourselves out of the trouble pretty quick. Regurgitation of MR is dependent on the size of the mitral valve orifice. Heart rate also determines the duration of systolic ejection. Pressure gradients across the mitral valve also are important, and regurgitation of more than 0.6 are considered severe. If you increase the SVR, the MR gets worse as well. MR is progressively insidious. Okay? It leads to left ventricular dilation, and the remodeling, unfortunately, is not reversible. Okay? And treatment before this occurs is paramount. And what you see in MR, okay, you see the following valvular pressure over volume curve. Okay? Your normal curve here. Okay, this is the normal. Okay, this disease process is actually here. Okay, it has to do with the actual mitral valve. It's supposed to close properly. In mitral regurg, depending on how severe it is, we'll do mild, and then we'll go to mild to moderate to severe. Mild is the valve still stays properly closed, and then opens here prematurely before the aortic valve. The aortic valve then opens here, okay, and you get ejection like that. So it's hardly noticeable. It's not a big deal. Okay. In moderate MR, it opens, let's say, mid-valve. Okay. It goes like this. Okay. And the aortic valve opens. And then severe is like this. And you can see that the effective stroke volume is actually doing what? It's decreasing. Okay. So the effective stroke volume is getting significantly impaired. So that's what tells you if you have mitral regurgitation versus aortic insufficiency. You have to look at this side of the curve, which is where the mitral valve disease is at, over here. Okay? And that's the degree of significance in regurgitation will tell you how fast that curve shifts over. The more rapid the slope is, the more severe the MR is. There's different kinds of MR, of course. There's acute mitral regurgitation, which is due to basically no compensation inside the left atrium. There's no dilation taking place. As a consequence, you get high left atrial pressures. This is the most common in the sense of myocardial ischemia. The chronic mitral regurgitation, on the other hand, is due to dilation of the heart, possibly left atrium with normal pressures. This could be from a congenital problem, a rheumatoid arthritis problem, chronic infectious disease, something that's chronic state. It's not something that's acute. In the chronic state, the difference between the chronic and acute is that the preload change occurs. Okay? Because the ventricle begins to dilate in that situation, you get an alteration in your curve patterns. Instead of your mitral, let's say this is normal for this patient. Okay? What you see is that the preload curve begins to flatten out. The reason it's flattening out is because the left ventricle is starting to dilate, okay? Because over volume. Okay? As it dilates, it leads to this alteration in your preload curve due to basically increased compliance. That increased compliance will lead to a starting point for the same pressure point. It's now over here. Okay? So for the same preload, you're over here now. Okay? Now this person has severe disease, goes out, okay, fires out, and they get this kind of pattern. Okay? So that's chronic. Okay, the chronic is a change in the preload curve. And it's still got that slanting over, that severe chronic MR. Okay? Notice that the isovolumetric filling of the heart is taking still place with isovolumetric. It's not shifting on this side. Okay? So this side is staying good. Okay? That would be indicative of aortic insufficiency, which we'll get to in the next hour. MR is a holosystolic murmur, leads to left ventricular hypertrophy and cardiomegaly, and echo findings are consistent. Mitral regurgitation, you'll see a large V wave here. Okay? The large V wave will start being seen on your PA occlusion pressure as an effect. The echo, this is what the echo shows. Okay? What I want you to understand is that severe shows you the increased MR jet, and your regurgitation fraction can be as much as 55%. The PA catheter, you get instead, this is the normal in the black. Okay? And what you see in this situation is you get an enlarged V wave. Okay? The more severe it is, the larger the V wave. Okay? So it begins to mimic the ventricular waveform that's inside the heart. V wave tells you how severe the MR is. Okay? What you do see is the PA catheter waveform is you'll get the following. Okay, you'll have normal PA waveform. Let's just draw it on here. Your normal PA waveform. Okay. Now this begins to match it on top of this. So instead of being your blue line, you'll start getting this. Okay. This is moderate, and that's severe. Yes? Atrial pressure does rise with it, but it doesn't change the actual configuration because there's nothing that the valve is compressing. There's nothing that the atrium is opening with the high pressures. Okay, so the actual waveform looks fairly normal. Okay, the actual pressure overall may rise, yes, but the actual waveform will look apparently fairly normal. What you do see is it jumps out at you as the V wave becomes very, very large. The worse the ventricle is pumping volume into the left atrium, the bigger the V wave becomes. It would be an enlarged V wave on the CVP. Right. There'd be no effect at all on the PA waveform at all. Okay? And this will all stop here, and we'll continue in the next hour.